Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Come in, we're open. Laissez-nous vous aider à atteindre vos objectifs de pratique. OPEN stands for the Ottawa Practice Enhancement Network, and it is the University of Ottawa Department of Family Medicine's learning network. Le RASPO se compose de médecins de famille de notre région qui collaborent pour faire progresser les soins primaires. We are inviting primary care providers to join the OPEN network to access several QI tools and view upcoming webinars and training events. Les participants du RASPO peuvent aussi participer à la composante dossier médical informatisé pour recevoir des rapports personnalisés. And this can be used to understand quality improvement efforts and support the residents in their FMRSP and QI projects. Le RASPO continue à innover dans le domaine de l'amélioration de la qualité. OPEN offers access to innovative approaches being studied across Canada. Pour en savoir plus, veuillez visiter notre site web ou contactez-nous par courriel.
Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain. We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Good morning, everybody, and welcome to the February edition of the Department of Family Medicine Grand Rounds. My name's Doug Archibald, and I'm the Director of Research and Innovation for the department. And it's with great pleasure today that I get to introduce today's speakers and to moderate the discussion afterwards. So our two speakers today come from the Bruyere Family Medicine Clinic. And I'd like to introduce, first of all, Dr. Sufian Zayed, who has graduated from the St. James School of Medicine and went on to finish his residency at the University of Minnesota Family Medicine Residency Program. He completed his last year as chief resident in their program. Subsequently, he went on to work for the Mayo Clinic Health Systems as a senior consultant physician. And he joined us at the University of Ottawa, the Department of Family Medicine, in 2018, and then took on the role of the Bruyere Family Medicine Center Unit Director in 2020. His areas of interest include sports medicine, point-of-care ultrasound, which he'll be speaking about today, hospital medicine, informatics, and health systems integration and optimization. Also, Dr. Vivake Umadat, who graduated from St. George's School of Medicine in Granada, where he spent his first 2 years of medical school. He then went on to train in both the United States and Canada during his third and fourth clinical years. He matched into the University of Ottawa Family Medicine Residency Program in 2019. He joined the Bruyere Family Medicine Center team at that point and is currently appointed as one of the chief residents there. His medical interests include sports medicine, point-of-care ultrasound, acute care, health inequities, for which he is also currently pursuing a Master's of Public Health degree.
Good morning, everyone. My name is Dr. Vivake Umadat, a PGY2 Chief Resident from Bruyère Family Medical Center. And I'm here with my supervisor, Dr. Sufian Zayed, the Bruyère Family Medical Center Unit Director.
Hello, everybody.
This morning, we're going to be talking about point-of-care ultrasound as it relates to my FMRSP project. So we both have no conflicts of interest regarding to this talk. So to begin, what is POCUS? POCUS is a goal-directed bedside ultrasound examination performed by a healthcare provider to answer a specific diagnostic question or to guide the performance of an invasive procedure. If you're not certain of all or part of the POCUS examination, you should not rely on those uncertain findings for clinical decision-making. I want to reiterate the fact that we're all learners here. So until we become completely comfortable with the technology, we should not use it to guide our clinical decision-making. So the advantages of ultrasound include its portability. It's a very safe diagnostic imaging modality. It can be used without radiation concerns. It's easily repeatable. It digitally stores the images. It helps to quickly aid clinical decision-making, and it has a multi-use profile.
Thank you, Vivek. In regards to POCUS in primary care, this is a rapidly evolving and advancing field. As you, or some of you recall, we used to have those elephant machines that would take up half a room while we're doing the ultrasound. And with the advancing technology, we have moved to a very small handheld device that basically fit in your pocket. This evolution and miniaturization of the technology allowed it to be portable and allowed it to be used for bedside or in-office diagnostics and performing procedures. In 2018, a survey across the family medicine residency in Canada that included 17 accredited programs showed that most programs do not have an established curriculum for point-of-care ultrasound, but believed that point-of-care ultrasound should be taught in family medicine residency, as it has been shown to provide positive outcomes. Resource barriers continue to be a considerable barrier in the sense that the devices themselves require an initial high-cost investments to obtain and to also to get trained on. And this continues to be an issue to be worked on. Some of the benefits for POCUS in primary care. We have a large amount of data and evidence that shows that the use of POCUS has some of the following benefits. It improves clinical outcomes, reduces failure rates and complications when used with procedures, improves accuracy of differential diagnosis, reduces time to treatment, lowers cost, decreases exposure to ionizing radiation of CT imaging, improves patient-physician experience when patients are involved in seeing their own anatomy, improves confidence of patient in physician diagnosis, and improves patient satisfaction. As you can see, the benefits span both the patient and the provider spectrums. Some of the diagnostic clarity examples. So I listed here some examples that we're going to run through in terms of what does POCUS provide for us in primary care when it comes to diagnoses. So it can help us differentiate congestive heart failure from COPD exacerbation. That is done when you apply a POCUS in the office. You can see, for example, bilateral B lines seen in the lungs indicating fluid in the lungs, which basically rules out COPD exacerbation as a culprit. It can be used to evaluate a kidney stone versus a ruptured AAA. It is very easy in an office to determine the size of the AAA, or to also look at hydronephrosis of kidneys or widening of the ureters. It can also be used to help differentiate DVT from a Baker's cyst. That is a bit more technical and does require a little bit more training to be able to look for deep vein thromboses. A Baker's cyst is quite simple. You can look at it and see it right away. This can change management drastically in the sense of, do I need to send the patient to a hospital? Do I need to consider anticoagulation right away? Or can we just do an aspiration and relieve the pressure from the Baker cyst? Abscess versus cellulitis. When you have a cellulitis under ultrasound, you can see cobblestoning versus an abscess. You see an hypoechoic structure, and that will also guide your diagnosis and management versus with doing an IND or not. In terms of a rotator cuff tear versus an impingement syndrome, this can also help diagnoses because we can use dynamic ultrasound in MSK medicine. In this case, it'll show an abnormal contact between the coracoacromial arch and the peritendinous tissue during shoulder abduction. Another two very important uses in primary care for diagnostic clarity would be the fetal position. Is the fetus vertex versus breech, as well as if the pregnancy is viable or is there a miscarriage by identifying the heartbeat. Overall, it will save the patient from costly, time-delayed ultrasound, CT scan, MRI, which improve the patient care. There has been several studies that have shown that the current medical student generation and residents desire an increase in POCUS exposure. The desire for further training in family medicine residency has been well established and quite evident. The studies shown that the need or the want to learn more about POCUS is highest in family medicine residency. POCUS is especially a powerful tool for providers in rural and underserved settings where access to advanced imaging and specialists may not be available. It is often family medicine physicians who work in these clinical environments, and having a stronger background in obstetrical ultrasound, which we all would do doing obstetrics, or at least doing our rotations in them, we are more well suited to learn other applications of POCUS. We definitely can see a significant involvement of POCUS in the emergency department. It is already part of their curriculum and has been on for several years. In terms of family medicine, we cover the majority of emergency rooms outside major cities are staffed by family physicians. So having POCUS as another tool for us to help with our diagnosis and management would be definitely welcome. In terms of a primary care and POCUS curriculum, this is a curriculum-based training, as it is a developed skill, just like doing procedures, just like reading ECGs. This is something that needs to be developed. So the curriculum must include competencies. These competencies include the resident or the learner knowing the indications, benefit, limitations of POCUS, being able to assess anatomy, physiology, pathology, being able to communicate the results of POCUS to patients and other treatment teams, being able to talk to the patients about the benefits and risks of POCUS, and learning how to best utilize it to decrease time to diagnosis and expedite medical care. In terms of attitudes and behaviors towards POCUS, the learners must understand that the POCUS is used to quickly find an answer to a specific question. It's an aid to diagnosis. It is not a replacement for physical examination and does not substitute a strong history and physical. It can enhance procedural competency and can rule in pathology. In terms of knowledge, this is to show that residents or learners can apply knowledge in regards to different anatomy and pathology to POCUS scanning. The list is quite extensive. I'm happy to share with anybody if you are interested. And in regards to the implementation process, we need to have a faculty champion, a customized curriculum that would be based on specific needs and clinical focus, having some didactic education, hands-on training, as well as quality improvement projects to look at the curriculum, and finally having some competency assessments like we do with procedures. One of the hardest or the most difficult challenges with this is that this also involves the training of attending or supervising physicians, and not only residents.
So now I'll talk about an introduction to POCUS as it relates to my FMRSP project and our environmental survey. So the inception of this project was rooted in both myself and Dr. Zayed's aligned interest in POCUS and its utility in the family medicine outpatient setting. Given the very limited and often varied exposure to ultrasound and POCUS in medical school, I was curious as to what prior knowledge and current interest our family medicine residents had in the technology and its clinical utility in the family medicine setting. The objectives of our project included to determine the baseline resident knowledge and interest in POCUS, to provide educational content on the fundamentals of POCUS, and 2 common outpatient uses of the technology based on resident survey responses and interest. And lastly, to determine if residents had an interest on additional formal ultrasound teaching in family medicine residency with the intent of potentially developing a formalized curriculum in our training program. So for the methods and study design for this project, I chose 4 sites affiliated with the University of Ottawa as my study population to capture the University of Ottawa family medicine residents as a whole. I chose Bruyère, Primrose, Civic, and the Montfort site. 2 sites were allocated as a control arm, and 2 sites were allocated to be in the educational interventional arm. And these sites were grouped based on similar numbers in each group. Pre- and post-intervention surveys were administered to the study population, who were initially blinded toward who was receiving the intervention. The interventional arm was chosen based on both myself and Dr. Zayed's physical location, the Bruyere Family Medicine Center, and our ability to provide an educational teaching session and continued ultrasound exposure and experience in clinic with our patient encounters. For that reason, Bruyere and the Primrose site, being sister sites, were chosen for the educational arm. Due to subsequent COVID-19 restrictions placed on residents, causing resident redeployment, often virtual home appointments, our intervention was changed from an in-person didactic and practical teaching session to a PowerPoint presentation that can be reviewed at one's leisure to capture the most amount of respondents possible throughout the study period. The data was then collected via our surveys and analyzed, and the results are as follows. So in terms of our pre-intervention period, 24 participants participated in the pre-intervention survey. There was fairly equal representation from the later defined control and intervention groups, with the control group having 13 respondents and the intervention group having 11 respondents. 2/3 of our pre-intervention respondents had used POCUS in their past, but the majority of them did not feel comfortable using the technology and would like to learn more about it. The majority believed it would improve their clinical decision-making skills within an outpatient family medicine setting. If they had the appropriate training, it would be something that they would consider implementing into their future practice. 2 of the most popular uses of POCUS amongst participants in the pre-intervention survey was for procedural guidance, including joint injections, and for prenatal examinations. In terms of our post-intervention, the results are as follows. The educational intervention presentation on the fundamentals of POCUS that was distributed and 2 of its high-yield uses was helpful to the residents in building their knowledge base about POCUS and its utility. The majority of respondents did not have formal ultrasound training prior to this study and this presentation, and 87.5% of respondents agreed that they would attend future ultrasound training that built upon these initial principles presented to them. The most effective educational course model picked by the residents was to combine didactic and practical learning in a formalized curriculum. So shown on the screen here is my pre-intervention survey and the results, along with the quantitative analysis of the questions. I just want to focus on questions 5, 7, and 9. As Dr. Zayed alluded to earlier, based on certain studies, you could see our residents did agree that POCUS would enhance the clinical decision-making in the family medicine outpatient setting. 83.3%, the greater majority, thought that this was a positive use of the technology. In question 7 here, you can see that the two most common or most desired uses of POCUS in the family medicine outpatient setting was for procedural guidance, including joint injections, abscess drainage, and paracenteses, and transabdominal scans for confirmation of intrauterine pregnancies. And question 9, it focuses on residents' opinion on having a formal POCUS curriculum built into our family medicine program, and 87.5% of respondents chose this option. On the screen now is the post-intervention survey and its quantitative analyses. I want to focus here on questions 4 and 6. So question 4 had asked the residents if our educational intervention and of the fundamentals of POCUS and its 2 high-yield outpatient family medicine uses, it focused on whether or not this was helpful for the residents. And as you can see, 81.3% did find it helpful. And in question 6, I had asked what learning modalities for POCUS training would work best for resident learning. And as you could see, 81.3% chose both a combined didactic and practical teaching session to be used.
Thank you, Vivek. Now we're going to move on to the actual educational arm intervention that we gave the residents for our intervention group. So I will be running through some slides that will highlight the basics of ultrasound. This is just to make sure that everybody is on the same level when it comes to baseline knowledge when it comes to POCUS. So feel free to kind of write down any questions and ask me during the Q&A session. So ultrasound probes, known as transducers, come in 3 different types: linear, curvilinear, and phased array. The curvilinear probe uses a lower frequency, gives lower resolution, but it does penetrate deeper. This is better used for abdominal, such as gallbladder, liver ultrasounds, EFAST, renal, aorta, bladder, bowel, and obstetrical/gynecological examinations. The linear probe uses a higher frequency range. It penetrates shallower, but it gives us a higher resolution. Usually used for soft tissue, MSK, pediatrics, ocular, thyroid, thoracic, breast, nerve, and most procedures. A phased array is a combination of a low-frequency ultrasound with a small triangular-shaped footprint with adjustable focusing and steering. This allows the beam for a wider field of view than linear probing and is ideal for cardiac and thoracic imaging. So for example, whenever you're doing a cardiac ultrasound, you're almost always using a phased array probe or transducer. Some basic conventions. The convention when the screen marker is on the left of the screen is that the probe marker should be directed to the patient's head. So each ultrasound probe, as you can see here on the picture number 3, has a little knob, a little a marker for you to tell you this is the marker. And that marker is shown on the screen that you get by the green dot here. So you know that, for example, if I'm placing the marker up, then the left side of the image will be up. This is done so that you have an orientation of what you're seeing on the screen, because ultrasound translates a 3D structure into a 2D picture. So for us to know which orientation is being done, we need to do that. So again, objects located closer to the probe marker will appear closer to the marker on the screen. So in this case, we can see B will be on the towards the head of the patient, but it's seen on the left of the screen. Now there are certain exceptions to the rule. In this case, most commonly it is the cardiac. In cardiac ultrasound, the probe marker is actually on the right, not on the left. And in certain other more specialized ultrasounds, such as MSK ultrasound with procedural guidance, this becomes dependent on the actual person who's performing it, which way they would like to align the marker to what area. Another thing that we have to be aware of, which is again the 3D structure and how we view and describe ultrasound imaging and orientations. We have 4 planes: a sagittal plane, a parasagittal plane, a coronal plane, and a transverse plane. I will not go into those in details, as we all know them, but there is a picture here to kind of explain and give a kind of an idea of how it looks like in 3D. Now, how does ultrasound work? Ultrasound measures the amplitude or the strength of a returning echo to the source. So it transmits sound waves and the reflected waves. We measure the strength of the reflection, and the computer software turns it into an image. Usually it is a reflection of the interface between different tissues or media. So different types of tissue will reflect the beams in a different way, which will allow us to differentiate between them. Reflection at an interface increases when the density difference between the 2 surfaces at the interface increases. So it's basically density based. Whenever we have, for example, when you do a liver ultrasound, there's nothing in the body that looks like a liver. So it's an immediate recognition when you see it. And this is just the density of the liver is very unique, and you can tell that right away. The ultrasounds do have settings that allow it to adjust to what you're scanning for, so that changes the gain, and we'll get to that in a second. There are a few things that could happen with an ultrasound that could make it look a little bit tricky. So the beams can be refracted into a new direction, which can sometimes give you a blurry image. Sometimes that can be corrected, sometimes it cannot. The beam can be scattered by an irregular or small interference. Like, for example, certain materials do not scatter the beam of the ultrasound. Like, you cannot really see a piece of wood in the scan, but you can see the shadow of it. And in some other cases, the beam is absorbed, which again gives us a different imaging modality that we see on the ultrasound. There are 2 things we usually see in the ultrasound, usually dark or bright and white, and dark and black. Basically, it's a hyperechoic when it's returning a stronger signal that has to be more brighter, and it's hypoechoic when it's returning a weaker signal. Sorry, so to kind of go more into that, fluids usually tends to be hypoechoic, so almost always they're seen as dark. Air in the lungs looks dark, versus if you're looking at a renal capsule, sometimes it can be quite bright. So probe movements, I'll go through those and I'll show the picture just to give a better understanding. There are 4 types of movements you do when you're using an ultrasound probe. You can slide it. So basically you hold it at a fixed angle and the entire transducer is moved on the body. You can tilt the probe. It's called fanning or sweeping. You basically hold it in place on the skin and is angled on the long axis of the transducer face to aim the ultrasound beam at a structure in different planes. Rocking the probe, basically you hold the transducer in place and it's angled side to side on the transducer face short axis, either towards or away from the orientation marker. And finally, you have rotating the probe, which the transducer position is held constant and the probe is turned along its central axis in a corkscrew fashion. The rotation tends to be quite optimal a lot of times in terms of allowing you to visualize, for example, a blood vessels. Doing a long axis, it looks like a long tube. Doing a short axis, it looks like a circular. Now, advances in ultrasound technology have allowed for biplanar visualization, especially for procedures. So, for example, you're putting in a central line. You can choose the biplanar aspect, and it allows you to see both the longitudinal and short axis views of the ultrasound, and you can really track the needle going in nicely. Those sort of transducer movements, sometimes seeing them in picture gives one better understanding of what each one of them means. We have multiple imaging modes. B mode is brightness mode or two-dimensional mode. That's what usually ultrasound is set to. You can change the depth on this setting. It's adjusted based on the position structure as well as the body habitus of the patient. You can also adjust the gain setting. Gain is basically adjusting the amplification of echoes returning to the receiver. When it's properly adjusted, fluid appears black, and solid tissues appear along the spectrum from gray to white. The M mode, or the motion mode, allows you to view movements of all structures along a single scan line over time. So this allows us to visualize rapidly moving structures. So when you're looking at a fetal heartbeat and you want to use the ultrasound to actually measure it, you're on the M mode, and the system will automatically capture every beat. Then you have Doppler mode, basically allows you to visualize the blood flow. Blood flow towards the transducer is red, and blood flow away from the transducer is blue.
Thanks, Dr. Zayed. So now we'll just briefly discuss two of the high-yield uses of ultrasound in the outpatient family medicine setting as chosen by our resident study population. So the first one is for knee ultrasounds for a lateral suprapatellar intra-articular cortisone injection or other knee injection. Okay, so for this imaging, the patient should be positioned supine with the leg of interest slightly flexed. You want to place the linear ultrasound probe in the transverse position as pictured in the left picture, number 14, about 1 inch above the superior aspect of the patella. The needle will enter the skin from the lateral to medial knee position along the long axis of the probe, parallel to the widest surface of the ultrasound probe face. You can see this visually in picture 15. In this position, it will be easy to see a large suprapatellar pouch to inject into if a joint effusion is present. If a pouch is not seen, you can ask the patient to contract their ipsilateral quadriceps muscle, which will open up the space for easier access and viewing. It is in this position that you can slowly guide your needle into and inject the solution while monitoring fluid flow, ensuring that it is inside the pouch and not extravasating into the local soft tissue. Now we'll talk about transabdominal ultrasound during prenatal examinations in pregnancy. So for this type of ultrasound, a curvilinear probe is used. It's often done to confirm the pregnancy and its location, help determine the baby's gestational age, confirm the number of babies, evaluate the baby's growth, study the placenta and amniotic fluid levels, and identify certain birth defects. So for this examination, you want to position the patient supine with the lower portion of the abdomen to the pubic symphysis exposed. A full bladder is preferred for this exam to provide an acoustic window to visualize the uterus and adnexa. And this is visualized in the picture number 18. To obtain a transverse view, you want to position the transducer immediately above the pubic symphysis with the probe marker facing the patient's right side. And you can see that the full bladder in the picture being pointed to is the acoustic window for the image. If you want to obtain a sagittal or longitudinal view of the uterus, you position the curvilinear probe indicator towards the patient's head along the midline of the patient's abdomen, immediately above the pubic symphysis. In your office, you would typically be conducting a transabdominal ultrasound in the first trimester of pregnancy. At approximately 6 weeks, cardiac activity is seen within the embryo, and in the first trimester, the crown rump length, which represents the longest dimension of the embryo, is used to estimate the gestational age. And this is often what we see on prenatal ultrasounds.
Thank you, Vivek. So to wrap this up, Bruyere to date POCUS, we have performed well over 100 ultrasound-assisted or guided MSK injections. These included knees, shoulders, hip injections, small hand joint injections, ankle injections, as well as SI joint injection. We have also done some carpal tunnel injections. We've also done over 20 prenatal ultrasound examinations, which mostly have been done for the purpose of reassuring the patients about the presence of fetal cardiac activity. We are able to provide paracentesis and aspiration procedures for our patients and have done them. And we have done assessments for CHF exacerbations, cholelithiasis, and hydronephrosis, as well as calculating BVR. Those are the 2 point-of-care devices we have available in our clinic. This concludes our presentation. Thank you all. Questions are welcome.
Thank you.
Well, maybe I'll go first.
Sure, Prisa, go ahead.
Given that I have benefited from POCUS and Sufian's expertise, I think certainly it has a role, and it's very important that we're including that in our curriculum. So I want to congratulate both Sufian and Vivake on including residents, especially in developing the curriculum, which is really important. I think, as you know, Sufian, one of the biggest struggles is in terms of getting the radiologists on board to accept our assessment. So I'm just wondering how you foresee overcoming this in the long term, especially if we're giving a training to our residents that still requires specific certification in the future.
Thank you, Parisa. The reality of the case is we may never get radiology approval. Under the current guidelines or law, really, to give us approval would mean that we would have to be able to read these pictures and therefore bill for them. So you'd have to basically have a radiology degree. So that is unfortunately out of the question. Now we do have the Canadian Point-of-Care Ultrasound Society, so you can do a course with them and you can get a certification from them. Basically, when you contact the college, they tell you, if you feel this is within your scope, go ahead and do it, but you're also still liable for any results you may interpret. My standard teaching to all the residents has been, we do this as an aid to help us increase our diagnostic accuracy or procedural accuracy, but we never really say we are 100% sure unless we get an official ultrasound read by radiology. So if we're unsure, we're just going to say we're going to get the official ultrasound. Now, having POCUS definitely gives us a bit more insight into saying, well, I can get this ultrasound in a week or two or in a month or two versus this needs to happen now. So this is kind of, sometimes it can save the patient time and decrease kind of harm to the patient from a delay in diagnoses. The only programs that have an integrated ultrasound teaching with them is actually right now would be the emergency medicine department. It's part of their curriculum. It's been there since 2012, I believe. Family medicine in Canada has lagged a little bit behind. In the US, they have a bit more resources, so they do have an official curriculum by the American Association of Family Physicians, and it's endorsed by the ACGME. So almost all 147 programs have some sort of POCUS curriculum. Again, still, it's all on-site you have to kind of do it on the on-site and make a call whether this is something that needs to be referred to radiology or not.
Great, thank you. Any other comments or questions? See, Dr. Bradley, you've made a comment around curriculum.
Yeah, just in addition to Sufian's comment that Emerge has a curriculum. So sport and exercise medicine, we have a year-long curriculum that's embedded into our program as well. Obviously, specifically focused on just the MSK aspect.
Yes, I'm very keen to collaborate down the line.
See, Dr. Kendall, you've got your hand up.
Thanks for the great presentation, Vivake and Sufian. It was really interesting. I'm part of a curriculum renewal process at the undergrad level, and there was a survey done of medical students asking what their priorities were for curriculum going forward. And POCUS stood out quite strongly as something that they wanted to learn, which I found really interesting. Like it stood out above many of what we would think of the core competencies for what would make a good physician. So part of our question has been, well, how can we build in what is really a technical skill, right, in many ways, into the learning for trainees, whether it's medical students or residents, in a way that still allows us to teach those important skills like professionalism and patient-centered care. So it's just a reflection. I don't know if you have comments on that. And I guess the second question would be, given there's maybe a lack of clarity on how much time or what type of curriculum is needed, how would you start to measure competencies among trainees to know that, you know, they were meeting whatever the check mark was going to be for POCUS training in family medicine?
Thank you, Claire. For the undergrad piece, actually, I am part of the committee that is designing the POCUS curriculum for undergrad. We just started meeting late last year. We actually have our third meeting today. So we are kind of working slowly to build that. So part of the process is hopefully to help us integrate the undergrad medical education with the residency program. We're still young and early, but we are looking at how we can make it a longitudinal experience, which kind of leads into the next aspect. There are preset competencies that are very well established for POCUS or any type of ultrasound. Like, for example, after proper didactics and teaching and hands-on experience, a learner or a resident must demonstrate at least 25 successful scans of the gallbladder. So you do 25 scans of the gallbladder with a supervisor, you're calling all the pathologies, all the anatomies, and then basically you are deemed competent to scan for gallbladder. It's kind of simple.
Lot.
It's a lot. Some of them are quite simple, like triple A's are like 10 because they're quite simple. Now the question is, the numbers are a little bit archaic, but they are somewhat needed, because if you don't experience the pathology, you don't see the pathologies, you may not recognize them in the future, because it is a very recognition-based system. You have to be able to take a look at the picture in a different angle and call the pathology. Hopefully, as we develop in the program, we'll be able to implement more of those. As I alluded to in the presentation, the biggest challenge is I need more physician supervisors to be trained on this, to be able to do this. Now, again, there are certain programs, whether it's the C-POCUS or others, that you do a course and then they do an exam for you, a hands-on exam to kind of test your competency as a supervisor or as a physician. And then we can bring that back to our resident curriculum.
Can I just ask a follow-up question? Because I think it ties into my question around undergrad. If you need 25 of one particular type of procedure, I guess we'll call it, to become competent, how could we possibly create competent residents in POCUS without removing huge aspects of the rest of the curriculum?
And this is where the archaic numbers come in. We've had residents who can pick it up within 5 scans and they're able to be very comfortable with it. We've had the residents see it once and be able to do an ultrasound guided central line, no problem. And we have others who struggle. So I think this is where the difficulty comes in terms of putting a number on it. Now, in a program like the emergency medicine, where they have 5 years, numbers are not an issue. They will get those numbers. In family medicine, we have to be a bit creative and maybe not follow a number-based protocol, but a competency-based program, just like we do with our in-clinic procedures. You do an IND, I see you doing it 3 times, you're comfortable. I can say, okay, you can at least identify 1, 2, 3, 4. There are certain levels of knowledge that are required for the POCUS, both from an anatomy, physiology, and pathology that need to be learned by the learners, or at least be known before they actually do the scanning. And I think that's also going to be a challenge in terms of how to do this. One proposal would be an introductory 1-day or 2-day workshop that all residents must attend in their first year to kind of get them up to speed with what POCUS is, and then it'll be a longitudinal experience. I would love to have everybody be able to graduate competent with POCUS, but at this point, I don't think that is an option.
Thank you very much, Dr. Zayed. We have a number of people that are wanting to comment. First, Dr. Wu, I think he's got something to say around the undergrad curriculum. Dr. Wu.
Yeah, Michael here. It's great to hear you speak, Dr. Zayed, Dr. Umadat. Thanks very much for that. It feels like I'm coming home because people who don't know me, I've trained at the Bruyère family medicine site, and then went on to emergency medicine now at the Ottawa Hospital. So thanks for letting me come back home. So with respect to the undergrad, they're great questions, and the reality is curriculum renewal, as you know, is going on, and there's a lot of work being done, and I can almost guarantee you that there will be a curriculum. There already is to a certain extent, but will be expanded at the undergraduate level. And so these talks of competency and numbers and different things, the expectation and hope is that by the end of medical school, very much as you expect a medical student to have the skills for physical exam, they should have basic foundational skills for POCUS as well. And so by the time they get into residency, say family medicine, it's not so much about learning the technical aspects, but integrating that into the clinical assessments and things. And so that's moving very quickly and collaboratively on a multi-departmental level with radiologists, cardiologists, anesthesiologists, and family medicine with Sufian on board as well. So there's a whole spectrum of medicine that is moving forward with the idea of POCUS. And so I don't think you need to worry so much about the numbers per se, because you can get exposure from POCUS from all the different rotations. I guess my question now is, given the evidence for POCUS, both in acute care, chronic care, palliative care, across the spectrum of medicine as a whole, how will family medicine and what sort of resources do you need to bring about a curriculum? I guess my question is, what are you waiting for, and wait any longer at your peril, so to speak? So I challenge your department in terms of what do you need to get this moving forward?
Thank you, Michael. I really appreciate it. And I'll send this over to Dr. Liddy. The program directors survey done in 2018 showed very specific numbers. The big 4 things were lack of adequate equipment, lack of instructors, lack of available time in the curriculum, and lack of funding available to support training. I think if we can start by chipping away at some of these components or breaking them down, that would be the first step in moving forward with a family medicine curriculum that is robust and inclusive.
Can I jump in, Doug?
Go ahead.
Yeah,
Go ahead,
hi.
Claire.
So good morning, everybody. I'm Claire Liddy. I am the chair of the department. Thank you very much for the overview, and thank you for the challenging questions. So I would say 2 things. So the first thing is that there is an openness, and I agree. What are you waiting for? Very much interested in hearing what the next steps would be in terms of a plan. So I think we're very open to developing curriculum, and as you said, almost sounds like we need to do a little bit of a catch up within our department. So the door is open. And so it really would take, what are the resources? How much would it cost? What type of faculty training do you need? So I need a bit of a, 1-pager that would just start to outline what the approach would be. And it definitely has to be integrated with what's happening at the undergraduate level. And I think that's the opportunity, is to create that continuum of learning. So do you follow up with me when you're ready? The second thing I would say is that the department, we're doing a lot of really neat stuff, and Parisa's involved in it and a few other folks in terms of looking at virtual reality and the whole shift to online learning and then gamification of department or of family medicine curriculum. And I would see that this as in terms of measurement for the competency could be ideal for looking at how you might actually do a bit of a hybrid learning approach. So it would be hard to have 25 patients who are going to come in, to get your level of competency for gallbladder in a 2-year family medicine training program, but you might have a few, and you could actually set up, as I said, a bit of a POCUS game that would enable residents and also undergrad students to do training. So I'm not familiar with the area in terms of the content, if this has already been looked at, but we do have some engineering students and again, some early work that has gone on looking at this. So I would encourage you to think about and really think outside of the box in terms of how we might apply some of that to it. And then obviously artificial intelligent approaches in terms of imaging to me would fit right in as well. And we do have a new postdoc who is from the Faculty of Engineering, and he's working with Doug and I on some other things, but available also for tapping into his expertise on the artificial intelligence approach. So imaging, as I said, is ripe and already a lot of work being done on that. The final thing that I'll say is I would encourage you as you're looking at the outcomes of this and if we implemented it and when you did the evidence, I didn't hear anything about choosing wisely, and I would think that that would be one of the ways to be looking at impact and reduction of other imaging. I might have missed it when I was looking at it, but I would, if I were you, weave that in, and again that would be ripe for also a research grant. So those are my comments. Thank you so much.
Great, thank you, Dr. Liddy. I'd like to give the floor now to Dr. Barba to give a resident perspective here.
Hey, thanks, Dr. Zayed. Thanks, Vivake, for that presentation. That was great. For people who don't know me, I'm one of the PGY3s in sport medicine, and I was a Primrose resident as well. And I think, obviously, being in sport med, like we use ultrasound, and like Dr. Bradley said, it is part of our curriculum in the PGY3 program, obviously with the MSK heavy component to it. In terms of like my experience as a resident prior to my PGY3, I would say having ultrasound skills, there would have been a variety of situations in which it would have definitely been helpful. And actually the fact that I had done some electives in sport medicine in preparation, to apply to that program, and had some exposure through that was actually invaluable. And there were situations in which I was able to apply those skills outside of a sport medicine setting. So in an emergency department or a hospital ward type of setting, and those were both in the context of joint aspirations for diagnostic purposes, and they were kind of trickier joints that you wouldn't necessarily have been as confident aspirating using like blind anatomic landmarking. The thing I will say is that as a learner, there's definitely a steep curve to POCUS, and so it's nice to hear Dr. Wu talk about the fact that like integrating some of the basics of ultrasound into the undergraduate medical school curriculum is something that's being looked at, because coming into residency with a basic understanding of just how to hold a probe and understanding like what different structures are going to look like on ultrasound would be invaluable, just to get that sort of head start. And then after that, it really is just about practice and applying. And what's key for that is to have attendings or supervising senior residents or whoever who are themselves comfortable and competent, because again, some of the experiences that I had outside of sport medicine clinics where I did use ultrasound in a procedural fashion, I essentially told my staff or whoever, like, I think that I can do this. And they were like, okay, I don't really know how to do it, but if you feel confident and competent, go for it and I'll watch kind of thing. But they weren't necessarily, they wouldn't have been able to assist me if something went wrong. Now, that being said, I had to know my own limitations in those contexts. And I think that's sort of come up in what we've already talked about, is that POCUS, one of the biggest aspects of it, I think, is that you need to know your own personal limitations, just like you need to in all other aspects of medicine. You need to know when you're confident in your scan versus when you're not, when you need more formal imaging versus when you don't. And that's, again, something that we can really only achieve if we have, again, the supervision from our staff or senior residents who are able to guide us through that.
This has been a fabulous discussion. A great example of a technological innovation that we could be certainly using more in clinics and our teaching. So thank you very much, Dr. Zayed, Dr. Umadat, for this great presentation.